The 19th century is called the century of hygiene, and the 20th is the century of medicine. The 21st century may be the century of behavioral change, changing everyday long-term behaviors, how we exercise, what we eat, is the key to adding years and quality to our lives. A very good afternoon to all. I, Jaskaran Singwahi, on behalf of Symbiosis School of Sports Sciences, under the Faculty of Health Sciences, extend a very warm welcome to our speaker for today's session, Dr. Aashish Contractor, Director of Rehabilitation and Sports Medicine at the Sir H.N. Reliance Foundation Hospital, Mumbai. Let's have a huge round of applause for Dr. Aashish Contractor. Glad to have you here, sir. I would also like to welcome Dr. Naina Nimkar, Director, Symbiosis School of Sports Sciences. Welcome, ma'am. I also welcome all the directors, delegates, faculty members, and students present here. Exercise is a powerful stimulus that can reduce and prevent the occurrence of cardiovascular and metabolic dysfunction. Therefore, exercise indeed is medicine that can improve the quality of life. And to give more insights on the topic, it gives me immense pleasure to introduce our speaker. A graduate from the University of Virginia, USA, Dr. Aashish Contractor was the head of the Department of Preventive Cardiology and Rehabilitation at the Asian Heart Institute. A very interesting fact about our esteemed speaker, which I would like to mention, is that Sir was in charge of the post-surgery cardiac rehabilitation of former Prime Minister of India, Dr. Manmohan Singh, after his redo bypass surgery in 2009. It is an honor to have an expert in the field of cardiac rehabilitation in this session, sir. Widely recognized as a pioneer of cardiac rehabilitation and sports cardiology in India, he is the Vice Chair of the International Council of Cardiovascular Prevention and Rehabilitation, which includes more than 35 countries around the world. An academic par excellence, he has recently authored a book, The Heart Truth, on heart disease prevention, and is also the Certification Director of the American College of Sports Medicine in India since 2003. An avid sportsman, he ran several marathons and did a non-stop Mumbai to Mumbai cycle ride of 329 kilometers, and in the process raised 1.2 crore rupees for children with cancer. He was also awarded with the Outstanding Zoroastrian in Medicine by the Zoroastrian Trust Funds of India in 2016. With these words, we welcome you and request you to give your valuable insights on integrating exercise medicine in healthcare, bridging the gap between theory and practice. The floor is all yours, sir.
Okay. Thank you. So this goes next. Okay. Okay. Great. So thank you, Jaskiran, for that very kind introduction. Good morning, good afternoon, everybody. I'm very happy to be here. Thanks to Symbiosis, thanks to Dr. Rajiv, Dr. Naina for inviting me here to this absolutely fabulous facility that you have. I've just seen 2 auditoriums and they both look super and world-class. So thank you for having me here. A lovely talk, Bhakti. Bhakti worked with us at the Asian Heart Institute, and she just reminded me in 2007, that makes me feel very old, because she said that was her first job, and I was already working for 10 years since then. Huh? So it's a pleasure to be here. I'm going to talk to you today on an interesting topic, which is integrating exercise. Let the lights be on, actually, just allows eye contact, yeah. Integrating exercise medicine with what we do. And I love the title of your symposium today, which is Transforming Healthcare. And why I find interesting is I did a similar talk a few months ago where I labeled it as transforming your patient's life. So it sort of syncs and in that. So let's get started right away. I'm going to be cognizant of time. I know I've got till 1:15, so I'll try and wrap up by maybe 1:05, 1:10, so we can have some time for Q&A as well. So this is just a picture of our hospital. It's actually 100 years old. It's going to turn 100 in 2 years' time. This is the Harkisandas Hospital, and this entire third floor where my pointer is pointing is our rehab department. I've taken it sort of standing this way, and this is the tower building behind, which is 19 floors. So it's been revamped a few years ago, and please do come and visit for those of you who visit Mumbai. So while I was actually preparing for this talk, I said, let's do some research and find out, what's the latest. And they were talking about this new drug, and they found that it reduces the risk of heart disease by 40%. Okay, this is not out yet. It reduces the risk of stroke by 27%. Okay. Reduces the incidence of diabetes by 50%. Risk of recurrent breast cancer mortality by 50%. Colon cancer by 60%. Alzheimer's, we're all worried about that, by 1/3. So as you can well imagine, something like this, if it ever came out in the market, what would happen with that company and how that company would do and how successful it would be. Also, how expensive a product like this is. And I was just kind of Googling and seeing how much it costs. And then I realized that, this is all it costs. So I'm sure many of you in the audience, before I put this up, kind of figured where this was going. This is actually a slide put forward by Dr. Robert Salas in one of the ACSM annual meetings I attended. I think this was like almost 7 years back, so I took those slides from him. And that's literally all it costs, because all of these, and everything I showed you is published data. It's not something I decided to make up for this Saturday morning. Okay, so this is all published data in the best medical journals of the world. And what's interesting, a lot of you are into exercise, and the trend these days is also to do barefoot running. So I said, you don't even need a pair of shoes. All you need are your own legs, your own 2 feet. And what's interesting, and I'm going to show you something which will should waken you up now. I'm going to tell you, you don't even need this, okay? Look at this, right? So you don't even need this. This is a prosthesis. Okay, this man doesn't have a leg, and there are men who don't have both. And this is actually a very good friend of mine, the person in the picture. His name is Major D.P. Singh, and D.P. sent me this picture of his in 1999. All of you are very young, but if you remember, 1999 was the Kargil War, and he had a very bad, a bomb blew off sort of quite close to him. And this is a picture he's made and he sent. So pretty much every organ of his body was completely shattered, and he lay in hospital for an entire year. He was in hospital for an entire year, okay? He showed me this. And this is his relatively recent X-ray. So all the red next to the red mark, you see all that little white snowflake-looking thing. That's basically shrapnel, which is still in his body. You can't take out shrapnel. And because of that, he's had a number of health issues. I won't talk about those health issues, but he's had a number of health issues, and he was in his hospital bed. And when he got out a year later, obviously there's huge mental trauma, depression, all of that. And he literally took one step at a time, and then he became India's first Blade Runner, and he started running half marathons, and he's encouraged an entire group, and all of these people in this group, if you can appreciate, they all have prosthetic legs, some one, some two. He calls the group the challenging ones, and they go around the country and they run half and full marathons. So it's quite impressive. So all of this, the point is you don't really even need legs, you just need heart, in a sense, to do it, okay? Since this is a scientific conference, I'm going to talk a little bit about, first of all, exercise is medicine as a concept, fitness and mortality, what's the data we have on that, a little bit about implementation, try and make this real life, and the challenges we face, because I know we have a very mixed audience. That's what Dr. Naina was saying. You got doctors, you got allied healthcare professionals, you got dietitians, you got students. So I'm going to try and make sure there's something for everyone. So this whole concept of exercise as medicine is now a movement. So the ACSM has actually patented this term, and every year when they have their annual conference, it's at the last week of May, first week of June this year in San Diego, so I'll be going in a few weeks' time. They start off the first day of the conference is exercise is medicine, and they have a website and they sort of show you how you can implement exercise as medicine even in your own practice, your hospital, etc. So if it is medicine, let's see the data we have. And I'm just going to show you 2 or 3 database slides in the presentation, and I'm going to run through them pretty quickly because the idea out here is not to stress on it, but just to give you an idea that indeed everything that we talk about has a scientific underpinning to it. It's not random that we are doing. So the Aerobic Center longitudinal study, many of you may or may not have heard of the Cooper Clinic. The Cooper Clinic's in Dallas, Texas. And Kenneth Cooper, Dr. Kenneth Cooper was the one who invented the term aerobics. Today we use the term aerobics very loosely, but in the late 50s and early 60s, and Kenneth Cooper is still alive, he came up with the term aerobic, and his center, which is one of the world's finest, and I've been there many years ago, they sort of started testing people who came to their centers from the 70s onwards, and they do the best sort of overall body thing. So most presidents of America also go there and get themselves tested. So they have actual testing data. Stress bars out here means more the mortality, okay? In this particular graph, pink is men and yellow is women. And in all of their studies, they essentially divided people into 3 groups or 5 groups of fitness. They took the fittest group as the top group and the least fit as the bottom group, and the third was in between. Or in 5, then they divide them into 5. And what they found and that's the basis for the next 3 or 4 slides I'll show you. Look at the people in the low fitness group versus moderate to high. Look at the massive drop in mortality that you get just by moving out of the low fit group. And the message of a lot of these studies is that you don't have to be in the highest group. As long as you get out of the lowest group and you start getting into a moderate fit group, you get great mortality benefits, okay? And CRF in all these slides stands for cardiorespiratory fitness. So you get great mortality benefits just by being moderately active or moderately fit. This one is looking at risk of hypertension, same story, okay? As your fitness increases, your risk of hypertension goes down. This is looking at cardiorespiratory fitness and breast cancer mortality. Again, as your fitness increases, your breast cancer mortality goes down. So you can do it pretty much for any disease condition. This is what they found. This is looking at strength. In the past, we always looked at only aerobic fitness. Now we're having more and more data looking at strength. Same thing with strength. As your strength increases, mortality is going down. This is all-cause mortality, and this is CVD mortality, cardiovascular disease. Okay? This is looking at strength, adiposity, and cancer mortality. Same story, same type of graph. As you're getting fitter, your risk of dying goes down. And the message in all of these is you don't have to be super fit. You don't have to run marathons. You don't have to do, crazy long distance stuff like I do, but you don't have to do that. All you need to do is get out of the lowest group. So just moving from being a sedentary couch potato to doing something gets you the biggest benefit for the effort that you put in, okay? So now this is something that I had presented to my hospital. Actually, this is something I presented to the ownership of Reliance the day we actually started the hospital. The vision was, and I hope this is a vision which can be implemented in health centers or hospitals, frankly, throughout the world, is to keep the patient at the center, and the goal should always be to get the patient better than before. I think in healthcare, we need to shift our mindset. All these years, the mindset has been about survival. So 20 years back and 30 years back, it was, person has a heart attack, or we just make them live, that's good enough. Person has had, has had a kidney transplant. As long as they live for 5 years, that's good. But today, that's not that anymore. Everybody's living. We need to desperately shift the focus to their quality of life so they can attain the highest life possible. And that's something which, I'm sorry to say, I don't think the medical community has quite caught on. A lot of the doctors are still into, the patient is living, right? We got them out alive and we've done this great surgery and they've got a new set of knees, they've got a new heart, figuratively speaking, or literally speaking if they've had a cardiac transplant, and that's okay. But I don't think that's enough. We need to get the patient to the best level that they can be. I had a patient of mine, in fact, I should have put a slide of that. He got a book. He's a patient who had Asian heart, had a bypass surgery, I think in 2012. And since then, we got him to run marathons, full marathons, not half, and he's run a marathon in every continent of the world. okay, and he's written a book on Dhananjay Yalurkar is his name, a book on running, every continent of the world. Now, again, the message is not that every bypass person needs to run a marathon. No, that's not the message. The message is the person can do it. There's no limitation. While 10 or 15 years back, oh my God, this has happened, just stay at home and be glad you're alive. That's not the message anymore. So, I'm proposing that the moment the person, so this is the community. So first of all, we got to start with a community and wellness outreach. So schools such as the School of Health Sciences, School of Sports Sciences must do a lot of community outreach from a preventive angle, because ultimately a country like ours, which has a very high rate of heart disease, very high rate of even cancer, we cannot afford to treat all of these people with bypasses and angioplasties. You just cannot afford it. You need to prevent them. And even if you can afford it, does not mean you should be doing it. When they come in, let's say they have a surgery or they have an intervention, we need to focus on early recovery after that. We need to not just do normal recovery. And a lot of healthcare in the West, especially in America, is dictated by insurance. So insurance wants to so-called kick them out of the hospital as quickly as possible. So their incentive is to get the person healthy to leave for the wrong reasons. I mean, it's for insurance as opposed to pure health, but that helps. In our setting, patients sometimes just linger on for a long time because the family also says, "Jara rest karo, thero," all that is not required. You get the person healthy. So we do this ERAS has become a buzzword, early recovery after surgery, right? Then we can do home care, and then they come back to our outpatient department to be the best they can be. So again, and the rehab team, which is part of this, this word multidisciplinary care, I think, is a very important word. And I also think that it's a term which is used and misused quite a lot. So the multidisciplinary team, this is just an example of the team we have, can have the physician, the surgeon, we can have physical therapists, nutritionists are of course very important, speech therapists, yoga therapists, neuropsychologists. So all of that form the bedrock. And I think it's time that we stopped operating in silos and there be true integrative sort of care between all the various branches of medicine, which does not exist today, okay? I'm just going to show you the next few slides, a few practices, a few pictures of what we do. That doesn't mean that, you need to do the same thing, but it's just something that we are doing and it's out there. So we are lucky to have an entire floor, and the floor is divided into many different sections. This is, if I want to call it, the so-called exercise section of the floor. So we've got this nice sort of exercise equipment, and the entire floor, so I think we've got about 15,000 square feet dedicated just for this. Now, I understand that especially in a South Bombay setting, to have 15,000 square feet, we are extremely lucky, and that's not a normal situation. But, you don't have to have this much space. You have to have the mindset. You can do lots of things in small spaces as well. So what do we do? On our rehab, and the center, we got cardiopulmonary patients, we got pediatric, we've got neurology, robotics for them, sports, musculoskeletal, yoga, transplant medicine, that's a big thing that we're doing now, mental health, so psychology, dialysis, chemotherapy. So we're actually doing rehab for patients while they're undergoing chemotherapy, meaning while there's medicine intravenous in their arm, not when they go home. While they're undergoing dialysis, they're sitting on the chair for 4 hours, they're anyway coming 3 times a week, 2 times a week for 4 hours, get them active. And there is enough and more research showing that by doing all of this, not only are you changing quality of life of the patients, of which there is zero doubt, but you're actually changing longevity, effects of medicine, and all of those what we in medicine call hard endpoints, okay? So we also monitor patients. This is just sort of me sitting and we're monitoring them, and I've got a little iPad so I can monitor them wherever I am. But today monitoring has changed, and these are, of course, we're using very expensive Philips systems, but you don't need that, and I'll show you how. This is how things have changed, and COVID has made it. So this is my therapist sitting, and this, if you can appreciate, this is the patient's ECG running real time on the screen, and she's talking to the patient on a phone. It can be as simple as a WhatsApp video call, and he's wearing a strap. There's a company in Bangalore called Fourth Frontier, and they've come out with this brilliant device where it's just a strap around the patient's chest, and the ECG is transmitted real time, not the heart rate. We have many heart rate monitors have been around for a long time, but this is the actual ECG being transmitted. And I don't think anyone in the world from the last 20 years, what I've seen, has a live ECG being transmitted with so much of stability. The ones which are very stable are cumbersome to use, and the ones which are easy to use tend not to be stable. I'm proud that an Indian company, Fourth Frontier, is doing this, where literally it's like wearing a strap, and I use it myself to exercise. In fact, I have it in the car. I should have got it here to show it to you. So she is making a patient exercise, and can be anywhere in the world, literally. And in COVID, we found that very useful for even doing COVID rehab. COVID rehab itself has become a big thing because, as you know, long COVID is affecting many people. So this is an example. This is actually my ECG. And this is sort of data you get. And then those who understand and read ECG, this is my data while I'm running. So have this type of what I call stable ECG during running is quite an achievement. And this had a heart rate of close to 150, 160, I think it was. So this gives you your heart rate, this gives you your ST changes, this gives you your breathing rate, impact. There's a lot of other stuff that comes. So this is sort of real-time data that I had shown you. Yoga is something that we do. I think mental health is very important. It's getting more and more important, especially with COVID. And this is how we adapt to COVID. So this is a patient in the center, and the laptop is there, and she's transmitting, and there are people sitting on the other end doing it via web. Okay, so there's no limitation to what we can do. Just some pictures of our patients exercising. Strength training is a very important component of everything that we do. We have a large number of pulmonary patients, so they're on oxygen while they're doing their exercise, different modalities. So what are some of the challenges in setting up something like this? One is obviously resources and space. Now, of course, in an institute like yours, it looks like you just got a lot of space, more space than we have in Bombay for sure. So space sometimes can be a constraint. Trained personnel, and this often becomes a chicken and an egg situation. You don't set up the center because there aren't enough trained personnel, and there aren't enough trained personnel because there aren't enough centers to give them jobs. So I was speaking to Dr. Nimkar, and she's talking about all the programs that you all are doing. So, the Symbiosis, Sports Sciences, as well as the medical school can come up with an army of trained personnel. And, as Bhakti said, a lot of the people working in her program are from Symbiosis. So, trained personnel are very important. Cost, and I don't think cost needs to be a barrier. For example, the Philips system that we use literally costs obviously lakhs of rupees. The one that I showed you, heart rate thing, it costs thousands of rupees. It's like 30,000. So I don't think for any program a cost like 30,000 is really a barrier, right? Priority, I think that's more important, both for hospital and doctors. Being a doctor, I must say that doctors are guilty of it. We're guilty of this concept that, as long as the patient has gone home and they're okay, how does it really matter? And again, I'm not saying all doctors, but that generally tends to be the trend. So you need to break that barrier more than anything else, okay? They need to be convinced, because if they refer the patients, truly refer, as opposed to just writing on a piece of paper, actually tell the patients they need to do something, I think it can be very useful. Challenges of attendance from the patient point of view, they can be, socio-demographic reasons, medical reasons, psychological reasons, financial reasons. I'll just run through them sort of very quickly and end up in the next 5 minutes. Distance to center. Now, I can again imagine that could be a barrier even for a place like this, because I don't think you are, for example, outside of Pune city. So, I'm not sure how much of a community you have around you. Anybody who needs to come here, I assume, needs to travel. So sometimes distance can be a barrier. But today with technology, see, this technology always existed. It's not that you couldn't. Skype and all were there for years. But suddenly, thanks to COVID, one of the sort of lining on an otherwise very dark cloud has been that it's now normal to do it. Now when you tell somebody, let's do distance, let's do a consult, it's mentally accepted. There was no reason we couldn't do it 4 years ago or 3 years ago. But that time it just wasn't normal. Right now your grandmother and grandparents also celebrating and cutting birthday cakes on Zoom. So it's not like it's just a mental thing, right? Older people less likely to participate, again, because of distance, cost, etc. And we've seen in studies that women are less likely to participate. Medical, physician endorsement is vital. Like I said, it's not just the doctor writing on a prescription, ke chalo, exercise. They need to actively explain to the patient how important and how vital it is. We found that CABG, matlab coronary artery bypass graft patients, bypass surgery patients are more likely to come to such programs. Simply, I feel that they've just been, if I may say so, traumatized more because they've had their sort of chest cut open, while a lot of other things like, say, an angioplasty is an equally serious thing, but because the person went home in 2 days, there really isn't any physical discomfort, they tend to take it more lightly and therefore less likely to follow up. Psychosocial reasons. Many of our patients, and especially in our country, we tend to be very, what's the right word? We tend to be very fate-based, meaning that nahi ye to hona hi tha, Bhagwan ne diya, jab jo hai wo hai, those kind of things. And they tend not to necessarily take charge of themselves and be the best they can. Abhi to umar ho gayi, I'm 60, I'm 65, you know why? And age does not need to be a barrier. I've got tons of patients who are between 85 and 90, 95. My oldest was 95, and he just passed away literally a few months ago. And he was one of the fittest people I ever met. Every time I met him, he would say, shake my hand and press it as hard as you can. I'll never forget a guy called Keki Cooper. So it's not that their age should not be a limitation. Financial, of course, this can be a barrier, because most patients in our country still tend to be self-pay, and even the ones with insurance covers some things, doesn't cover some things. But ultimately, it will be covered, because insurance companies, once they see the light of day and they realize that keeping a person healthy, spending that 5, 10, 15,000 rupees and preventing another hospitalization, which is 5, 10 lakh rupees, is ultimately a very sensible investment to make. So I think that this will change, okay? So just again, just couple of, I literally pulled these out yesterday to see what the latest was. This is in the NHS, the British Health System, the National Health Service. And it was very interesting. They call it the Active Hospital Pilot, which was a qualitative study exploring the implementation of a trust-wide sport and exercise medicine led physical activity intervention. Trust-wide means in the NHS is divided into, they call it trust. So each unit of hospital and the GPs around it is called one trust. So they are actually looking how, and the paper is like a 15-page paper, so obviously I'm not going into details, but they're finding and they're exploring how does the physician get involved in making patients more and more physically active. Today in the world of cancer and oncology, so exercise is medicine and oncology. Again, these are all papers pulled out within the last few months, engaging clinicians to help patients move through cancer. All of that is very important. Cardiovascular disease was the largest cause of death worldwide. Even in India, I won't say was, it still is. But cancer is unfortunately fast galloping up. As we're getting better with cardiovascular disease, cancer is coming up, and we don't have as much evidence in cancer as we have for cardiovascular disease, but that evidence is mounting. Certainly quality of life issues, no question, but even in treatment, in terms of preventive, recurrence, all of that, physical activity is having more and more impact. There's more and more research coming around it. So again, I feel that a university such as yours, which seems to be very progressive, which has so many different faculties working together, I think you have the wherewithal to make great change, to make transformational change, to use the title of your conference, and to really impact lives, to publish papers. India sees probably the largest number of patients in the world. Indian doctors and healthcare is the best in the world. But the one area where we are very, very, very sorely lacking is research and publication, where we are nowhere. Let's just face what the truth is, okay? And this, again, is an opportunity to do all of that, and academic and research institutes should take the lead in this. So just a couple of things, this was, they started this concept of walk with a doc in America, and they contacted me, and I was the first so-called Indian walk with a doc. We did it, and everybody got so excited. The Sunday Midday put on their front page. This was before COVID, of course. They put us walking with our patients literally on the front page of the paper, and inside there, like a 3-page spread just on this. It's just a mixture of our patients. This lady is my anesthetist's mother. She's 85 now, and she's still doing good. So, people found it very interesting. So I just put that one up. Okay, I'm just going to end with these couple of pictures, and I'll tell you why I selected those. These are pictures actually I had selected when I was doing one international conference on low and middle income countries. Do you know which city this is? Yeah, it is Mumbai. It's a picture of Mumbai, and this could be a Manhattan skyline. You know, it looks very beautiful. That's actually the Saifi Hospital. This is a hospital, and it looks very beautiful, and this is Mumbai. But this, from a different angle, is also Mumbai, okay? So literally, it's two cities and everything. And the reason I'm putting these up today is to essentially say that, you know what, we really have a choice in terms of what we do and how we do. We can do usual care, which we've been doing all these years and all these decades, or we can do it better than before and to make our patients better than before. So thank you very much for your time and attention. And as I promised you, it's 1:05, so we can have Q&A. Yes, sir. How are we going to organize? Just put the hand up and ask the question, or? Yeah.
Yeah. My question is, so I myself have been treated for diabetes and for metabolic syndrome. So I've reversed all of that. But my question is, there is a lot of push by doctors to actually push pills vis-a-vis give lifestyle modifications. Like I was given a statin, I pushed back, I said, I don't want to take the statin. But there may not be somebody who is as aware of it. So how much push is there from the medical authorities to say, okay, you have to prescribe a pill vis-a-vis give someone a lifestyle intervention?
Okay, so I'm happy that the first question asked only is the most controversial question. So, and let me see how I will navigate this. So firstly, congratulations on reversing your metabolic syndrome and diabetes. I think, okay, let me answer honestly. I think the way medicine has been practiced or the way systems are set up, there are incentives to prescribe medicine, okay? And I don't just mean direct financial incentive. That's not what I'm trying to say. That the system is geared up. I mean, big pharma, obviously, and I don't want to say anything negative about big pharma because big pharma has changed the world, okay, in a good way also. There is money in pharmaceutical. There is no money necessarily in telling someone to sort of exercise more. And I think, and again, I don't want you to misinterpret this. When I say there is money, I just mean that the whole industry is geared around, I mean, there is seminar after seminar on the next wonder pill that comes out, okay? I was in America in the mid-90s or late 90s when statins just came out, and I know how many fabulous seminars I've attended. I know every time I went to American Heart Association, you had like Hollywood coming and being chief guest and talking and things like that. An exercise science seminar, there is no Hollywood coming and there's nobody coming. Once Michael Phelps came, but other than that, there is nothing. But the whole machinery is geared towards promoting medicine. The machinery is not geared towards promoting exercise. Reimbursement needs to be there, and people are making steps. The largest healthcare system in the US is called Kaiser Permanente. Kaiser is based in California, and they work on a managed care model, which means people pay them, or they pay hospitals a certain amount of money, and then so normally in our setups, every patient coming in actually is income for the hospital. The way they do it is they take money up front. So whether you come in or not, they've made their money. So every time you go in, they're actually losing money. So it is in their interest to keep patients out of the hospital, okay? And therefore, they have taken very progressive steps. Once at an ACSM meeting, only the chairman spoke to us almost 7-8 years ago. How we have the vital signs, temperature, pulse, respiration. So now all over the US, tobacco is taken as a vital sign, meaning at every visit you must ask about tobacco. Now in Kaiser and other places, exercise is a vital sign, meaning every visit that a patient comes, you must ask about exercise. Whether they come for a knee pain, a stomach ache, or a headache. The same way that you'll check with pulse or BP, exercise is a question you ask about. So it's got to be that culture. So, baby steps will happen, but right now things are not in favor of promoting exercise as much as they are in favor of promoting pills. So, and I think a lot of that is also education-based. When I finished my MBBS, how many lectures did I really have on exercise? I think it's close to 0. right? How many lectures did I really have on tobacco cessation, which is the foundation of healthcare in many ways from this? Zero. Okay? But today, I'm sure there are things happening. I'm sure there are a lot, it's changing a lot. So yes, change is happening, and we need people to catalyze and accelerate the change. Yes.
Yeah, so first of all, thank you, sir, for such a wonderful lecture. And exercise is medicine. So actually, I do believe this because 2 years before, I underwent one ligament tear surgery. And because of that, again, back pain was started. And just by doing cycling, swimming, and other exercise, now I am totally painless and like I'm doing everything. But now the question comes into my mind because of my past experience. When I underwent that surgery, the one thing was only in my mind just to do exercise and keep myself fit, and I succeeded also. But there are so many exercises like aerobics is there, swimming is there, cycling is there. Then what exercise in what amount we should choose to be to maintain ourselves physically fit, or we should recommend to our patients to be physically fit?
So Dr. Nimkar is starting a BSc in exercise science. You can attend that and you will know. But honestly, the question is very open-ended. This is the sort of stuff I can stand here for 2 hours and talk about. So, we can talk offline. But bottom line is a combination of for general health. I'm not talking about for you specifically for a ligament surgery. General health is 3 to 4 days. Basically try and be physically active all the time. Okay, be as physically active as you can. And 3 to 4 days a week, try and get in structured aerobic exercise, walking, cycling, running, swimming, etc. And at least twice a week, try and get some strength training in. That's a general guideline. There's a lady out there, yes, she had put her hand up a while back. Just ask loudly. Bichara is going to get too much physical activity.
Very, very engrossing talk.
Thank you.
My question is on mental health and physical activity. Like for cardiovascular disease, I know there would be a structured exercise rehabilitation program. So when a patient of mental health, say even the major psychiatric disorders like say bipolar, or even the minor ones like depression or PTSD, etc., when they come to us, we tell them ki theek hai bhaiya, exercise karo. But we really don't know what type of exercise we should tell them to do. Now what I wanted to ask you, you being the expert in the field, is there any structured exercise protocol that is made exclusively for patients of mental health? And the second question of mine is that, if possible, is there any anecdote that you would like to share with us where a patient of mental health issues has recovered with an exercise regimen? I think it would be, it would be very inspirational for us. Thank you.
So, thank you. There is a lot of data today which shows that exercise helps patients with mental health issues. There is no question about that, whether it's depression or anything. It almost acts like a little pill. So somebody with a minor depression or things like that, you start getting them physically active, it definitely helps. And there's a link between sort of mental health, depression, cardiovascular disease, all of this. I'm not aware of, if I may use the word, any difference in exercise prescription that you would do for a mental health patient versus what you would do for anyone else, right? The same principles will apply. The only difference, and this is not only for mental health, for anyone, the first thing as a practitioner you need to do is to make sure you are able to convince the person in front of you to actually do it and to stick to it. I always tell people, whether it is anything to do with lifestyle, whether it is exercise, whether it is diet, the best diet in the world which you can make up, which a person doesn't follow, is worse than a very, very simple diet which the person ends up following, or the most complicated exercise prescription which somebody doesn't end up doing is worse than telling someone, you know what, just walk 20 minutes, 5 days a week. So the main issue here would not be the nature of the exercise you do, but to get into the person's head, literally speaking, and figure out what they would like to do and tailor a program joint with them. Your last bit is, have we had anything? Yes, there have been a lot of people who had depression, who had even suicidal thoughts, and exercise has helped them. But I cannot say it's exercise alone, because somebody with suicidal thought, if somebody comes to me with suicidal thought, I'm not going to say, oh, go run every morning and don't see the psychiatrist or psychologist, right? So it's part and parcel. So everything helps. So for example, in our setup, every person who comes into our onco rehab program, cardiac rehab program, pulmonary rehab program, they all see a nutritionist, they all see the yoga person, they all see a psychologist, everybody, okay, even if they feel they're great. Now, that's a screening visit. Now, if they're great, obviously you won't keep calling them back to the psychologist, but if they're not great, then we'd call them back. So we need to identify those. So there is no doubt that exercise helps, but again, we don't need to get into this only exercise. If somebody's got a serious mental health issue, they must be referred to a professional and not say, let's only do exercise, okay? Yes.
So thank you for the wonderful talk. I wanted to ask whether exercise can be considered as a part of behavioral therapy for children with behavioral problems or ADHD, or in schools as a normal, or in colleges also. Because when we grow up, it's not a part of our syllabus. So, and we lose the link with exercise. So can it be included in the syllabus of the university or college so that we do not lose a link?
So it should not, can it be? It must be, M-U-S-T. No doubt, no debate, no question. It must be, okay? How each person does it is up to them. I hope that Symbiosis leads the way and we can convince them. I'm hopefully meeting Dr. Raju after this, so I'll tell him the students want a way to get more active. And frankly, you got a good campus. See, one of the biggest barriers is not having a place to do it. There's no, I mean, you got a good campus. Right now it is very hot, but still, maybe early morning, late night you can. In fact, I'm instituting a project in the hospital which even the hospital doesn't know yet, so you're the first to know. We're going to try this concept of exercise snacks. That's a new kind of a thing, which means like 20 seconds of exercise, 30 seconds of exercise. So literally, telling, maybe leaving, I'm just giving an example, a dumbbell in a set of, one pair of dumbbells in one corner of the thing. Every time you pass by, lift it up 5 times. 10 seconds, 15 seconds. So just different ways of getting creative. Ultimately, where human behavior is concerned, it's very, very hard to change behavior in a long term, right? Today, for example, where weight is concerned, every single person in the world knows, yes, exercise more, eat less. Even the person who's overweight, they know that. But how do you do it and stick to it is hard. And we need to appreciate that. Those who are already very much on that end, they will not need that motivation. But the idea, like those graphs shown, is to get everybody slightly up. That's how the health of a country improves. To get the bottom 10% up by 10%. Not the top 90 to become 100, that's not a big deal. It's the bottom 10 to get a little bit higher, okay? Yes.
Good afternoon, sir. Thank you for the very insightful session. I'm a student of postgraduate doing nutrition and dietetics, specializing in clinical nutrition and dietetics. So my question is that we often come across this news that an XYZ person passed away due to a cardiac arrest and had a history of hitting the gym regularly, was physically very active. So what is your take over it? And the age is, like a middle-aged person, 30, 45.
Yeah.
So what's your take?
This is a topic which actually I've done countless podcasts, lectures, symposiums, webinars. I keep telling people again and again, exercise and fitness, we are using the term interchangeably, gives you protection against a multitude of illnesses and diseases. It does not give you immunity. Because you exercise doesn't mean you cannot have a heart attack, you cannot have diabetes, you cannot get stroke. It reduces your risk. But to get those diseases is multifactorial. It's like driving a car, right? I drove today from, say, Mumbai, Pune, and on the highway, there are so many reasons why I could have an accident, right? I may be talking on the phone, I may be distracted, I may be driving rashly, somebody ahead may cut me badly, there may be water on the road, my brakes. So my brakes should be working very well. If my brakes are working well, my chance of having an accident will go down, you agree? But just because my brakes are working well, doesn't mean I can't have an accident, because there are so many other reasons. Just because a person is exercising, doesn't mean they can't have a heart attack. So it's a multifactorial thing. So, these anecdotal things don't mean that you this. Also, of course, if you're exercising and you're getting some warning signs and symptoms, you need to pay attention to that. That goes without saying. So that's how it works. Yes, madam. Okay, so I think we have a last question, right? Then we'll wrap up after this. So where yoga is concerned, and I've been asked this question many, many times, yoga is very interesting because, why is it interesting? Because yoga, or yoga as it's known, usually when you refer to it as a way of life, actually it's a way of life, right? Where they have the ahar, vihar, vichar, all of that. It's not just something specific. So when you say the word yoga, for some people, yoga means the way of life, which is an excellent way of life from a heart-healthy point of view or a health point of view. Or it could mean sitting in front of a TV, doing 10 seconds of heavy breathing and say, I've exercised. So in yoga, there is again so much variation. You have simple meditation exercises which are great for mental health. And then you have a lot of hatha yoga which are also part of physical, like doing a proper Surya Namaskar is a proper strength training workout, if you want to call it that. So yoga ought to be incorporated as part and parcel of what you're doing. So if you're doing breathing, that's part of your mental health. If you're doing a lot of intense physical exercise and if you're doing it continuously one after the other, then it's a bit of an aerobic thing. If you're doing it with breaks and doing very intense postures, then that's a bit of strength training. So it has to be incorporated in this. Okay? Can it be a complete package of, Of course, yes. Of course, yes. And this, my 3 days a week and 2 days a week is a very, very generalized thing, right? There's a lot of mix and match within that, depending on what the person wants to achieve. Yeah. So thank you very much.
I know there are going to be more questions for Sir, but of course, Sir is here for lunch with us. So if anybody has any more questions, they can meet with Sir at lunch. But nonetheless, I request Dr. Colonel T. Vijay Sagar, Dean Symbiosis Medical College for Women, to felicitate Dr. Aashish, Contractor. Can we have a huge round of applause?